Dr. Pilar Trelles is a certified child and adolescent psychiatrist. Dr. Trelles has expertise in autism and related neurodevelopmental conditions and has received specialized training in the utility of genomic medicine to better understand these conditions. Her clinical and research work has been dedicated to improving access to care for under-resourced communities. By establishing strong community partnerships with national and international stakeholders, she's developed initiatives that improve healthcare disparities and build capacity in the community to improve research participation in ethnic and racial minorities in autism research. These webinars are made possible thanks to generous donor support. If you're able to contribute, please visit our website at autism.org. And now I will turn this over to our speaker.
Hi, everyone. Thank you, Denise, for such a kind introduction. And thanks, everyone, for taking the time to join us today. This is such a broad topic, and there's a lot of information out there. And unfortunately, also data that sometimes feels conflicting so while we will not go through everything, I've tried to bring some important concepts that I hope can support, families and clinicians to direct patients to kind of the best treatment. So what we want to learn today is I want people to leave as with the sense that they've gained some understanding on what are the evidence-based pharmacological treatments in autism, and what are some of the strengths of those studies, but also where unfortunately the evidence is failing us. Then, I want people to kind of get a sense of how child psychiatrists that see children with autism and related conditions plan treatment. I want us to talk about kind of the benefits and limitations of medication for the treatment of psychiatric symptoms. And obviously, we'll leave some questions, and I hope I'll get to some of this as we're going through the talk based on my experience, but we'll have some time for questions at the end where I hope any concerns that anyone has or anything that is not clear can be answered. So we are, I've divided the talk in kind of 4 different sections. So we'll review some important concepts. I think there is a lot of kind of evolving terminology and different understanding of, kind of what autism is and talking about this spectrum. We're going to talk about research and, how it's done in very generic terms and what are some of the limitations that research in autism has today, and where do we stand, and why, despite efforts, we still continue. We're still not at the place we need to be with kind of pharmacological treatments in both for autism core symptoms, but then also for psychiatric symptoms. Then we'll kind of go over the most common associated symptoms that are treated with medication in autism and related disorders, and about the evidence that we have on medication. And I will try to share as much as I can my own kind of, my clinical experience based both obviously on the literature and the scientific evidence, but then also on, many years, basically just at this point, this is the population that I really only work with. And then we'll go over some conclusions, and hopefully we'll have time to answer questions. So one of the important thing is to kind of review some of the terminology. So we're going to talk a little bit about what is autism, which I'm sure you kind of all have an understanding. Then there's this kind of 2 important topics that are associated with it, which is this idea of having kind of atypical developmental trajectories, and why this is important as we are thinking about pharmacological treatments for children that have atypical developmental trajectories, even if they don't have, like, quote unquote, what we call ASD as a syndromic diagnosis. And then we'll go over the comorbidities and what a comorbidity is, which is an associated psychiatric condition or medical condition that might be more common in kids with autism. So when a patient comes to my office and a parent of a child that has autism or maybe intellectual disability or a very atypical developmental trajectory, even if they don't fit in each of these categories, which we know are limited by where kind of the science has brought us to date, the first, what we are thinking is kind of what we know about the evidence, what we can treat with kind of behavioral interventions or can be treated by kind of some of affiliated disciplines, and then if there are any symptoms that can be addressed with medications. So generally, when a family comes to me, there are kids that have already an established diagnosis, many times have already, although this is not universal, but have already had very comprehensive evaluations. We have a good sense of where they're, if they have a diagnosis of autism, what are their cognitive strengths of limitations, and what are the supports that they have. And when we are making that assessment, we kind of figure out, what are some of the services they're getting from our kind of affiliated disciplines? Are they getting speech, occupational therapy? How is that supporting, these children? And then, of course, what are some of the behavioral interventions? So that is, and those things are really what continues to treat kind of the core symptoms of autism that we'll talk about. And then generally when they come to me is because they're struggling either with irritability or aggression or difficulties paying attention, or lots of frustration. And kind of our role is to figure out if medication, and when I say our role, I mean kind of myself in teaming up with the family and the caregivers, if there is a medication that might be able to really help and support these children with these associated symptoms. And that's what we are going to talk about. So as you know, autism spectrum disorder and many of these related conditions, autism spectrum disorders, are behaviorally defined conditions. So basically that means that they are based on subjective observations, right? And they are composed of two sets of symptoms that we know, like deficits in social communication and repetitive and restrictive behaviors. And this really is, it's kind of a large spectrum. What is important to know is that associated symptoms of autism often cause significant impairment. And the other side of this is that treating these associated symptoms can truly improve quality of life. We're going to go into more detail into some of these and why treating these conditions can be helpful and how do we approach them. But I also want you to see that there's, I have here like kind of medical comorbidities, because many of the children and the families, I see their kids have like, either, very significant allergies, or they have GI symptoms. A lot of kids struggle with constipation. There's all sorts of, a number of different things that could also impact the child's behavior, especially when they do not have, the language or the abilities to communicate how they're feeling. So all of those things are kind of in our mind, but addressing those can truly impact the quality of life. So I've found and learned over the years that while, autism really kind of impact the day-to-day kind of child's ability to navigate the world, it's not the symptoms itself that would cause necessarily, them to be irritable or inattentive. It's generally the associated symptoms, and those are the ones that we can truly treat with medications. So the second part of this is that when we are thinking about these conditions, because we have these behaviorally defined conditions, and they can be, they're kind of subjective. You have the clinician with a caregiver. Then let's not forget that we have a social environment that has different expectations. And the age of development. So it kind of becomes, as it's quite complex. That's why some kids sometimes take a long time to get to us. But what really happens is that we are kind of, if we, I don't know how much you can see me, and I wish maybe I had a slide about this. When we diagnose other things in medicine, where we have what we call biomarkers, even like a seizure, we can do a test. We can do blood work for diabetes, and that will confirm. So there are clinical symptoms that we see from the outside, but then we have biomarkers that can confirm it. In autism, we are not quite there. We have some in the forms of genetics and in certain conditions and in certain associated features, but in general, autism spectrum disorder as a condition as such doesn't have like in general biomarkers, especially when we're talking about this broad spectrum. And what happens is that then that has impacted research. So when we do a clinical trial in any condition, okay, let's say I will, hypertension, which is something I'm going to make it. I'm not even going to go into psychiatry, which is still for many things very subjective because we have all of these symptoms that we are assessing clinically rather than with kind of blood work. But hypertension, you can measure it. It's pretty clear. You have it defined. You know exactly what it is. There's no question. It's not that I think that's a high blood pressure, but then you measure it and it's low. It is truly grounded in kind of very concrete objective evidence, right? And the first thing for us when we're doing a clinical trial is our ability to really define the population, okay? So that is critical. And with autism, because we're still at the level where we have these behavioral symptoms, right? That has kind of impacted our ability to really create a population that is more homogeneous. So let's say you have hypertension, you define it, you have a new agent, you give the medicine, and then you have a bunch of people that get better. And this is a positive trial. You have more people clearly that get better than people that get worse. Because autism is a heterogeneous condition, we really are not there quite yet. We cannot kind of group, there are some studies and that might use kind of a genetic first approach that might be able to group kids together in more efficient ways for research, but that's not where we are. So because it's a heterogeneous condition, it has many kind of phases. And because of that, it just makes it very difficult to kind of truly define a population based on like that kind of concrete evidence that we are talking, and that has impaired our ability to really advance treatments. The other part of this is that we have all of these kind of associated genetic conditions. So not genetic conditions, sorry, like clinical syndromes. The other one that is often associated that comes about half of the children with autism present with what we call intellectual disability, which is like, again, another kind of in some ways, although we have more, we're measuring kind of cognitive ability, it's still kind of a broad range of abilities and spectrum, and it presents differently in children to children. So I guess what I'm trying to say is that these kids, I think what we can say about all of them is that their brains are developing in a way that is not typical. And that because of that, and they can be very different from each other, it has been difficult to really create studies that have a very well-defined population, and that is critical. So for years, what the field has said, okay, let's do a trial on autism. We will try to, from a clinical standpoint, we'll try to get the kids as similar as we can. So we'll get kids with autism, none of them will have intellectual disability, and they will present with irritability, let's say. So we have this population, let's try this medication. And then most of them do not get well. This would be in face value, this is a negative study. But then there's a couple of kids that get better, right? And we know that it doesn't matter that they got better, the study is negative, but it could be that that medication is helpful for a subgroup of those children. And the reason I'm bringing this up is not to try things that are not, safe or approved or anything like that, but it's just to prove why, although we have only 2 medications that have been so far approved based on clinical studies for the treatment of kind of for using autism, for irritability in autism, which are risperidone and Abilify, many times they are not the first line. And this is because of that. So we are borrowing information from what we understand from typical development many times to assess, because we know that we're using the evidence and we are trying to advance the science, but that also have been limitations. And I'm spending a lot of time on this because I think it's important that you kind of have those conversations with your doctors if you're kind of trying to figure out what is the best approach, obviously grounded in what we understand about the medications, the symptom presentation, kind of the side effect profile of treatment. So going back to this idea of a symptom domain approach, this is what we do. So a child has, well, I'll focus now on autism, although this in many ways applies to children that might not have kind of autism, quote unquote, but have kind of very atypical developmental trajectories. So this symptom domain approach is kind of reflective of everyday clinical practice. And what we do is we have a child that have a diagnosis having this condition, really talking about a brain that is developing in a different way. And that just sets the standard of how we're approaching the case, right? We know that we have to, we have to kind of tease apart the symptoms that we have. We need to figure out what are the symptoms in the context of what this child has in terms of what is their baseline. And then we need to use the available evidence in combination with what we understand of how some of the medications that we know are very safe work in kind of the general population, to see if that's helpful. And for that, treatments need to be really thought out and be provided. We do very, very slow titrations of medications and try to really work closely with the family to ensure we are identifying the best treatment. So when we take a symptom domain approach, the most common things that we treat and for which we have great symptoms are ADHD symptoms. That's a great example. And we have medications that can be very helpful for associated, like inattention, hyperactivity, impulsivity symptoms, irritability and disruptive behaviors, which can be associated, to anxiety, to ADHD, to communication deficits. So those are the things that we need to kind of figure out. OCD symptoms that go beyond, kind of the classical repetitive and restrictive behaviors that are part of the ASD. Many of the kids that we see have EEG abnormalities that might have nothing to do, that might not be clinically relevant in terms of epilepsy, but that sometimes can help us kind of selecting treatments. Then we have, sleep issues, feeding problems, motor problems, immune dysfunction. So what is important here, and this all comes in this like kind of huge spectrum, right? I think what it's important to kind of understand is that when the brain is developing and you have all of these symptoms that are kind of a function of brain development, there are many other things that are also secondary to brain development, like motor development, which is related to feeding, or the ways kind of the neurons are talking to each other, and that sometimes can be picked up with EEG abnormalities. There's many other things that can happen, and that's just a function of a brain that is developing differently. So deciding on the pharmacological treatment, as I said, we take this symptom domain approach, and these are kind of the most common symptoms that present and for which we get consulted. And I'm going to kind of move and present the evidence that we have and how we approach treatment. But I wanted to give you that introduction because I think it's important for us to understand when you go to your doctors why, like, if you have, if risperidone is FDA approved for the treatment of irritability in autism, in many other conditions that would be the first line of treatment, and sometimes it is, but because risperidone also has some side effects, it might not be the first line of treatment, and your doctors might try something different that has less side effects. So moving to kind of the evidence, atypical antipsychotics have been the most studied medications. They can help with many kind of symptoms, and they were studied for irritability and hyperactivity and actually repetitive behaviors. In order for the FDA to approve a medication, traditionally we have 2 large clinical randomized trials, which basically means that neither the clinician nor the family knows what the child is getting. So you get, and you need to have 2 of those that are positive and that have improvement in the outcome measures that you selected. So the 2 medications that have been approved are risperidone and Abilify. However, some of the other kind of atypical antipsychotics, or what we call dopaminergic agents, and people call them neuroleptics, are kind of used broadly. Sometimes we have children that do not respond to neither of these, so we try some of the other medications, and because of what we understand about the evidence. So risperidone is the most studied medication. Its kind of efficacy for irritability was established in 2004. There's an FDA approval in 2006. These are the 2 studies. We saw a significant improvement in kind of irritability in symptoms. However, there's a couple of caveats. One is that risperidone, unfortunately, is associated with significant weight gain and metabolic symptoms. The studies are also kind of short, although they were kind of open label extensions after that. So that is one, and this is kind of the mean age of the children in the study. something that is important, and it's also like a point that I kind of want to communicate, and this we have found over and over again, not just with risperidone, but with other conditions, is that kind of the synergistic effect of behavioral and pharmacological interventions. So there's been a lot of studies that utilize both, providing and giving parents the skills that they need to be able to better support their children when they are really struggling with some of these symptoms, and medications. And what we find is that over time, it kind of helps with the severity of the symptoms, although this is not a lot, but it was significant. But what I love here is that it truly, that the dose that you use in the parent group was lower. And this is very important for something like risperidone or Abilify, because the metabolic side effects can be dose dependent. Some of the side effects can be dose dependent. So if we can get away with a lower dose, it's better. Abilify, kind of very similar. In theory, the reduction was a little bit less than risperidone, and the weight gain profile was better. However, in clinical practice, and anyone that sees many of these children will tell you, look, you really do not know. I think there's children that have, terrible metabolic side effects from Abilify, which was supposed to be kind of the safer alternative and do beautifully on risperidone, and vice versa. There's kids that, have almost perfect response to Abilify and they don't do well on risperidone. So while these studies provide information, I think sometimes in clinical practice, we need to kind of take a stepwise approach. I generally start with risperidone because I feel you can get away with lower doses. But the truth is that different clinicians have different approaches. I think very important is to have these conversations with doctors and clinicians to try to understand and make the decision as a team. So that's that. As I said, kind of the fine print is, these medications cause weight gain. Here, so generally, and I, the more I practice, if I have a child that I know will need a medication like risperidone, and we've tried everything else, and this is really the only thing that is helpful, I have become a little bit more, I don't want to say aggressive, but more intentional when I introduce metformin, because it can help with weight gain. It does not revert the other metabolic side effects. It helps with triglycerides and weight gain, but not necessarily with kind of the insulin resistance and increased glucose. There is ongoing research on these new medications, GLP agonists, so Zepbound, Wegovy, done in adults, some in adolescents, that seem to be very promising. Clinically, I've started seeing some significant benefits. You see, so I think that's where the field is going, and those medications too seem to have an impact on kind of the insulin resistance and diabetes. Another medication that has been used for irritability, there's a few trials on valproate, Depakote. It's also a medication that's been around a long, long time. Trials were very similar. They were looking at kids with irritability. They used the same outcome measures. And it's helpful. Unfortunately, Depakote is another medication that doesn't have the best side effect profile. We know it works. However, it's not, despite having more research than some of the other studies, some of the other medications, many people will be a little bit hesitant to use it as a first line because of the side effect profile. So, and we'll talk more a little bit about medications in the family class later. In terms of ADHD symptoms, methylphenidate, which is plain old Ritalin, has some evidence. It can be very helpful with attention. What is important to know is that kids with autism and atypical development in general are significantly more likely to have side effects. So we have to be very careful in how we are dosing these medications. I generally take a very kind of slow stepwise approach, because I've seen kids get like really irritable. But again, this is something to kind of consider. So you wouldn't start the same necessarily doses that you would start in children that have typical development that have ADHD. What is important to know about ADHD is that just like autism requires, that the core treatment of autism is behavioral interventions, the treatment of ADHD is truly pharmacological agents, and we have decades of research on that and on their safety. And treating ADHD can be extremely helpful because, as you know, if a child has autism and they require all of these behavioral interventions, that is asking them to be really kind of learning things all the time for hours and hours, right? These patients are like the hardest working individuals I know. They're all the time doing some sort of therapy, but for that you need to be able to pay attention. You need to be able to access the treatment. And if you have issues with kind of executive function, your ability to direct your attention to something, it will be very hard for you to get the benefit of those treatments. So treating ADHD, while it would not necessarily kind of improve the autism per se, it can allow the child to be available for treatment and then act synergistically with the behavioral interventions. So again, this is a meta-analysis, which basically is that they got all of the studies they had on methylphenidate and looked at if it was helpful or not. Consistently, we saw favorable outcomes. But what it's important to know is that the doses that were helpful were half of the doses that you would otherwise use in kids with typical development. So generally, these doses, these are different studies on methylphenidate. For typical development, you go 1.5 milligram kilogram dose, and you're seeing here that it's less than half. Another medication that has been widely studied is guanfacine. This is an alpha agonist or non-stimulant. This is a study on Intuniv, so extended release guanfacine. We saw improvement of symptoms. And one of the things that we see with this medication also is that it helps a little bit with kind of anxiety symptoms. So when the other part of this is that when a child has ADHD, and they are not able to kind of access the therapies, they also are getting in trouble all the time because they're doing the wrong thing, they're being impulsive. They get all of this negative feedback from the environment, and that can create a lot of anxiety. So treating the ADHD sometimes in itself helps improve the anxiety and the associated irritability. Atomoxetine is another medication. It's also a non-stimulant. I really like it. One of the limitations of atomoxetine is that children can only, you can only take it if a child can swallow a capsule. You cannot like open it or trash it. But it has, evidence that it can be very helpful. It can be very helpful for kids that do not tolerate stimulants. More recently, and right now there's studies on this. There's a new medication called Qelbree or viloxazine. That is something that you can actually open and sprinkle on food. So that has actually opened treatment options for many children that do not tolerate stimulants, cannot swallow capsules, and now we have an option to treat ADHD. This is a kind of a large study in atomoxetine, which was, it's 2014, so 11 years. I wish I could tell you there's all of these new medications, but we are still using the same that we were using 11 years ago with some modifications. But we saw some improvement, and with atomoxetine as well, some of the kids show some improvement in, although this is not significant in anxiety. Again, the same idea that when you combine what we call parent training, or basically, giving parents the skills and resources they need to support their children better. Sometimes the things that we need to do are not intuitive, really can have an additive effect on the response to medications. And not only that, but in kind of open label extensions, then we actually see that over time it has all sorts of positive impacts long term. Again, same here. The other set of symptoms, so repetitive and restrictive behaviors, it's part of the core features of autism, and there's been studies that have looked at that and see if there's anything kind of helps with that. They can be aggravated definitely by anxiety. And there's kids that have kind of more what we call classical OCD, where they get very intrusive thoughts, and that generates a lot of repetitive behaviors. There's a little bit of different, so some, experts consider the symptoms that respond to medications kind of classical of autism. Some others feel, no, this is really a comorbidity they're not getting because of the medications. I think at the end of the day, it's less important why. That's more of an intellectual exercise. I think it's important that they can help. So serotonergic medications, or SSRIs, and these medications have been around forever. We know them very, very well. Here we have some others that are not SSRI, so this is an SNRI. But what it's important is that they can be very safe. We have a lot of evidence, both in kind of children, adolescents, adults, and like medications like risperidone, for example, we do not need to do like blood monitoring when they're well tolerated. They're very well tolerated. Research has been like really mixed, and I think it's because of that first slide that I showed, that we probably are not able to pick up the kids that respond to it, but because they are very safe, I think they have a utility, and many children with autism are on many of these medications. So many of the open label studies have been positive, placebo control, which is really the ultimate evidence. They are mixed. The largest study was done in a medication called citalopram or Celexa. There was, as you see, like absolutely no difference with placebo. So that was kind of disappointing. But that doesn't mean that we don't use it. The approach most doctors take is you start at very, very, very low doses, because just like with ADHD medications, children with atypical development are more likely to have side effects. So you start at a very low dose, and you have to be very, very patient. Once you reach a certain dose, if you know the child will tolerate, you can actually, use a more traditional approach to increasing the dose. But early on, you just do it very, very slowly. Risperidone and Abilify also help a lot with repetitive behaviors. I get very conflicted about this, because I find that when Risperidone and Abilify are introduced early in treatment and repetitive behaviors do get better, behavioral interventions are removed. And by any means, I'm not saying to change treatment if it's working for your family. But I see many times these kids later in life, they're having a lot of metabolic side effects. They were doing better in the school setting, but they're not getting the behavioral supports they need. And they are having a lot of kind of metabolic side effects, and we're kind of stuck in treatment. So they definitely can help. And I think when these symptoms are really life impairing and not responding to anything else is critical. But I guess also what I'm saying, it's very, very important to, as much as we can, given the side effect profile of these medications, to try to hold off as much as we can in starting them. Sometimes, and again, like there's some children that need them, they respond very well. Sometimes I give them, and it's I ask myself, why wouldn't we start this before? But this again is kind of an ongoing treatment and partnership with the family. More of the same information. Finally, sleep. Sleep, as many things that depend on brain development, follows a developmental pattern. As you are well aware, little babies sleep different than toddlers, that sleep different than school-age children. And as we get older, kind of, sleep patterns change. From studies in kind of individuals with typical development, we know how those patterns change. Older adults have very light very light sleep. Their brains do not go so often into those deep stages of sleep. And if you have a toddler that sleeps very well, you know that when they fall asleep, there could be an earthquake and they might not wake up. And the reason I'm kind of reflecting on this is that this is important when we're thinking of children with atypical developments or kids with autism, because many of them have atypical sleep patterns. And again, this is just a function of their brains developing a little bit different. What is interesting is that sometimes it's almost like they don't need. I mean, sometimes obviously that not sleeping is impacting their behavior during the day. I've also met children and adolescents and adults that almost seem like they need to sleep less, or they have more fragmented sleep, and that doesn't seem to have necessarily an impact on them. But it definitely has an impact on the family. And sometimes we find ourselves, treating and ensuring that the child sleeps through the night is critical for the patient, but it's so critical for the family, and it's something that can have a huge impact in the quality of life, and something with which we can help. So as I said, it's a pervasive problem. It affects the family at large, and definitely we have a lot of research that shows how poor sleep really impacts a parent's ability to care for their child. It impacts the whole family quality of life, and it really causes a lot of stress because caregivers generally do need their sleep. So there's not a lot of so the one agent that has been studied the most is in autism is melatonin, which is safe. Melatonin, unfortunately, is very short acting. So kids will fall asleep, and sometimes they just wake up and they have no idea how to put themselves back to sleep. And that's when we start looking at other agents. So there's different medications that are used. Clonidine is another one that is used and has been studied, and it's pretty safe. Clonidine is also used for ADHD and impulsivity, and it has kind of short and long acting formulations. But there's many, many different medications that are used: trazodone, Remeron, etc. This is something, but the one agent that has been studied is melatonin, but others are used. So going back to this idea of clinical trials in autism and related conditions, what we try to do really is, when you are taking this approach, is figuring out who are these kids that might respond. So let's say you had a study on anxiety in autism, right? And that study found that using something like fluoxetine or sertraline or citalopram, which I show you that medication, a serotonergic agent, the study as a whole was not positive, because a lot of the kids had side effects and they didn't improve, and it kind of even out with the positive outcomes. But then there are a couple of kids that really did very, very, very well. And the reason why doctors will prescribe these medications, although the study was negative, was because of that. And because those medications have less side effects than the one that does have evidence, which is, for example, the risperidone. So in conclusion, why are you here? I think this is in the wrong place. But anyway, I guess this is also a conclusion. So there's a lot of medications that have been not necessarily properly studied, but they are used frequently in kids with atypical developments and autism. And this is a large kind of, it's a questionnaire, so obviously it has limitations of caregivers, and they ask about many, many different medications that impact behavior and psychiatric symptoms that are used in autism, and some that do not have a lot of evidence. And they're just looking at, are these medications used, what they were used for, were they helpful, and if they had any sort of side effects. So they basically had these two, important outcomes, and they look at things as, was it helpful, and then side effects. So, we don't have a lot of, clinical trials on lamotrigine. Lamotrigine is a medication that we use a lot. It's a mood stabilizer, antiepileptic medication. Going more deeply into it right now, we don't have time. We would need a whole other hour to talk about some of these other medications. But what I want to show is that while many of these medications don't necessarily have their studies, they're used. And you can see things like these are carbamazepine or trileptal. These are medications that are used for different indications and seem to be very well tolerated and not necessarily have a lot of adverse effects. Here you can see SSRIs, and this is obviously in clinical practice, right? These are the medications that children are getting at a time. But you can see that, despite those negative studies, they're still using clinical practice, and they can actually have impact and support. And then you have others like Adderall that seems to be, cause more trouble than not. So I think that's an interesting result from this national survey. So, kind of the final thoughts, and to close, is that the foundations of the treatment of autism and kind of related conditions continue to rely on behavioral interventions and kind of educational interventions. Pharmacological approaches can be extremely helpful, and they can be extremely helpful in terms of taking care of associated symptoms and comorbidities. The heterogeneity of autism and how we define it today, and the large broad spectrum that we have, really has been a major challenge in research and our ability to continue advancing the field. But we are going there. Treatment is going to always be a dynamic and evolving process. I have patients that I've been treating for 10, 12 years, and over the years, the response to medications has changed a little bit. I have kids that, have severe anxiety, and when I started seeing them at 7, 8, they didn't do well on an SSRI, but as they've gotten older, they actually are able to tolerate them, and they ended up doing very, very well. So I think these things need to be constantly revisited and approached. When you start a medicine in a child, that doesn't mean that he will necessarily need to take it for the rest of his life. This is something that you should always be assessing and always kind of putting in that balance of benefit versus risk. It's very critical that you have a very strong alliance, with the school, of your therapy providers, your medical providers, because it's, you will be kind of the experts on the child, and you will use all of this additional information to identify what's the best treatment option. And that's it. So now we have 15 minutes for questions.
Okay, great. Well, thanks for making time for questions today. We do have a lot of questions, as I'm sure you're used to on this topic. So I'll start with some sort of just general questions and themes that we got. One of the big ones was about just, can you define, and this is putting you on the spot a little bit, but what irritability is? So when people are thinking about these assessments that they do, is there any kind of standard battery of tests that they do, or what does that look like?
Yes, so that's a great question. So I think irritability at its core is just kind of getting like easily frustrated with things, and then kind of losing your temper, and that can kind of evolve to having temper tantrums, aggressive behavior, and again, like anything that is kind of behaviorally defined is again, it's highly subjective. It needs to be interpreted in the context of development and what is happening around. But if you have any sort of pattern of behavior that is interfering with day-to-day function, then it's something that you need to figure out where it's coming from. So, irritability and, might just be a function of you're having a difficult day. The main one of the things that is under irritability and more frequently is anxiety. We've all had, we've all felt angry because we are anxious at some point. You are going someplace and you're late, and you're really worried that you're not going to make it, and all of a sudden, like, someone is driving very slow in front of you, or there's a red light that is taking forever, and you start getting a little bit like, irritable. Or so that is, that's something that many people experience. But high anxiety is associated with low frustration tolerance, and that kind of leads to irritability. There's different ways to answer the question in terms of batteries to measure what we call irritability. So irritability is kind of a symptom, but again, it can be secondary to poor emotion regulation because of ADHD, can be secondary to anxiety. It could be secondary to a child being very frustrated because they cannot talk or communicate, and they're just getting angry because they cannot make their needs known. There could be because they're not sleeping well, and that just has kind of their coping mechanisms low. So that's kind of one symptom. And the role of the specialist is to figure out and assess it in the context of everything else that it's happening, and just trying to understand what's under that, losing your temper more easily, and why is it interfering with day-to-day function. I don't know if that answers the question.
I think it does. Thank you. Thanks for diving into that. There are questions about, you mentioned that in the last decade, there haven't been a lot of new medications that have come out. And Risperdal originally was used for what they then defined as schizophrenia. I mean, do you have any insight about why there aren't new medications or new medications that might be on the horizon?
So there are, I mean, they're just not part of day-to-day clinical practice. So maybe we should rephrase that. So there's definitely new agents that have made it into the field. We're also learning better. We also have more data on, we might have like an agent, for example, methylphenidate or Ritalin, methylphenidate. And we've learned over the years ways to pack it and deliver it in the body that actually will make a difference on how the child responds to that. So we have that. We have other, clonidine, a new version of clonidine, which is a medication that has existed for a very long time in liquid form, which is extended release, which is, so far showing very nice benefit for kids that do well on clonidine, but clonidine is very short acting. So we do have kind of newer ways to pack medications and get them if the insurance will approve for it. And then we have different pathways that are being studied right now, and they are not necessarily, either we don't they're not approved for all conditions. So there's a medication which is a factor similar to a growth factor that is used, that was first, like we saw in kids with very profound disability and autism and some genetic syndromes, was better. It was approved in red, and now there's a lot of studies that's a neuron. There's a new type of antipsychotic, Cobenfy, which is right now being studied in kids with autism and irritability. It has a different mechanism of action, and it doesn't cause weight gain, but it's not approved. So it's not that these things are not there. There's a lot of things moving in the background, but they're not necessarily part of day-to-day clinical practice or accessible to everyone. The other part of this is going back to this idea of research and what I was trying to show you. We still have limitations in how we are defining populations. So right now, a lot of what we're doing is, you limit as much as you can the definition of the population you're studying. So you try to make those borders more constrained, and hopefully that will give you a population that are more homogeneous and it's more aligned with the same kind of biology, right? But we still don't have great ways to do that. The best way we have to do that is by using genetics. So there's a lot of genetic syndromes that are associated with, autism. And there's studies that have been done in those specific genetic syndromes, because the idea is if you have a genetic syndrome, if you have a genetic condition or genetic mutation that has created a variation in the way your neurons talk, or you have a specific biology, and then you can group those kids by kind of biological alterations rather than what is happening only clinically. So, for example, Fragile X is a condition where there's kind of ongoing studies. Phelan-McDermid syndrome. There's a number of them. So that is happening. But again, we still do not have great ways to capture positive outcomes. We still rely a lot on clinician observation. We still rely a lot on caregiver report. And just kind of referring back to that question of irritability, right? You can totally see how then that can make a study and outcomes and messy. So that I think the science is helping us understand more what is happening in the brain, is giving us more ideas and pathways of what medications or agents can happen. There's definitely a lot of studies in basic science, people that are growing neurons, trying to understand what agents work and not. But we have limitations on how then we take that into the community, from how do we define that population, how do we capture those outcomes, how do we follow those children over time. So that definitely is kind of interfering with how the field advances.
So obviously everybody's different. Like the way that medication interacts with each individual person is really different. And I know there's been a lot in the news this week. There's been a lot of autism news. I that is unrelated directly to psychopharmacology and what we're discussing today. So we've had a lot of questions about those questions about leucovorin and those kinds of things. obviously these are things that people need to speak individually with their clinicians about. They need to talk to their physician about it. Do you have any comment on that or?
Um, so leucovorin has been something that has been kind of coming up. There's, I think, like with social media, there's, parents here and there kind of sharing stories. Um, Obviously, so this is folic acid, and I think the way it's delivered, it just kind of gets better into the brain. But I can tell you what we know, and again, this is not a kind of a comprehensive response. Most of us can if can get those nutrients into the brain. Like our bodies have ways to convert it and get it into the brain. So that's on one side. It could be, but we don't have enough evidence to say that this is a treatment that should be approved for everyone. And we certainly do not have enough evidence on the side effect profile. So when I sit with a family and they ask me about a treatment, it's critical for me to understand what, you cannot make a decision if you cannot balance the benefit versus the risk. And we don't have enough with leucovorin specifically to balance the benefit with the risk to make like a recommendation that will impact everyone that have autism. So I think we have to be careful. We have to have conversations with our doctors and our medical professionals. We need to look at the literature and then consider treatments that are not mainstream, always in the, as you're associating what we understand of the side effects, right? What evidence is available, and have I tried something that for which we have a lot of evidence that we know it's safe, that can help my child, right? So as limited as some of these medications that I presented are, at least we know them, and we know what to expect of them, and we have a lot of evidence that then you can incorporate. None of these things are going to be like, sometimes it's clear. Many times with these conditions, with what we are talking, it's not. And that's why you need to weigh those things. So you cannot weigh something for which you do not have enough evidence. And isolated cases and small studies is not enough to make a recommendation for everyone.
So, right, you're saying that you can't generalize that out at this point. There's not a big enough sample size, and then people should speak to their doctor. That the best approach to that is to work directly with their clinician and move forward in that way. Well, let me ask you related to that then. So we got some questions about people who tried SSRIs with their kids when they were younger, and now they're older, they're teenagers. So if they didn't work when they were young, is it still, if their clinician's saying maybe give that a try, are there sometimes different outcomes as people get older with these medications?
Absolutely. Yeah, that happens all the time, and vice versa. I've had kids that were doing great on SSRIs early on, and then all of a sudden they stop working. So yes, I think if they haven't been tried for a while and you're working with a clinician, I think what it's important is just to start at very, very low dose and be very patient, and see if there's any benefit. So you just take kind of a more cautious approach. And the reason SSRIs are given many opportunities is because they're, when they're tolerated, the side effect profile is quite good.
Okay, great. Do you have any insight about why some of these medications have such a profound impact on gastrointestinal symptoms? Like why, or do they know? I mean, do we know why?
Yes, we do. I mean, remember that so they're acting on neurons in your brain, right? Just as general, I'm going to give a very generic answer, and there's a specific answers, but remember that our GI tract is highly innervated. So if you have a medication that is impacting the function of the neurons and brain and certain molecules, some of these molecules are also present in other parts of the body. So serotonin is extremely, we have a lot of serotonin in our gut. That's why SSRIs at the beginning, or if you take them without food, will cause nausea. So yes, we are not, we're not just like, we are complex organisms, and many times the same molecules that you find in your brain are present in your gut. You have neurons that go into your body. So there's a lot of reasons what that is. And depending on the specific medication, those are questions to have with your providers.
Well, thank you so much for your time today. You answered a lot of questions. We could not get to everybody's questions, so I tried to do sort of general scope, but certainly we didn't. I did get questions about if people wanted to come for who are in your area, if they wanted to come for treatment at Boston Children's, should they just contact the facility, or is there a best route for that?
Yes, absolutely. I think we have a service we've that called the Neurodevelopmental Disability Psychiatric Service at the Outpatient Psychiatric Clinic. So you can call the hospital and request to talk to outpatient psychiatry and a consultation for sure.
Able to connect them. Okay, great. Well, I'm so grateful you came today. We'd love to have you back. It was wonderful.
Thanks for having me. I hope this is
such a big topic for our families. It's such a complicated topic, so we really appreciate it.
It is. Thank you so much for having me, and I hope it was helpful.
We'll see you another time.
Yeah. Bye.